month to the MedWire News podcast. In this two-part edition, we're taking a look at the questions thrown up by the results of the Integrated Canvas programme, the cardiovascular outcomes trials for the SGLT2 inhibitor canagliflozin, presented at this year's ADA. Of the three medications in its class currently approved in the USA and Europe, canagliflozin is the second to report on cardiovascular safety. The EMPA-REG investigators reported results for empagliflozin in 2015. Approval of the SGLT2 inhibitors marked the first availability of an anti-diabetes medication that targeted the kidneys, reducing their reabsorption of glucose, resulting in lower levels in the blood. And healthcare professionals working with patients with diabetes have seen clear benefits beyond the additional glycemic control.
I recognized patients feeling generally better. And while I think about what better means, better might mean glycemic control to me, but better to them likely meant weight loss. And I'm promised by the fact that we didn't see a plateauing of weight loss in Canvas, that it in fact did continue to the end of the trial. But now that we understand the importance of the diuresis effect of the class, perhaps well-being could also have been, people in this trial likely had a significant degree of fluid retention because of their background insulin, undiagnosed heart failure, they were more complex, they had renal dysfunction. So maybe the feeling better was that we were actually offloading fluid without knowing very much back in the day when we first started Canvas over 6 years ago. And it was sort of the first, dabble within that area.
This was the experience of Berard of the Health Sciences Centre, University of Manitoba in Winnipeg, Canada, who was a site investigator for both Canvas trials. The Canvas results, although positive and good news for the medication class as a whole, are on the face of it less impressive than the EMPA-REG findings. Canvas reported a 14% reduction in the primary cardiovascular endpoint, compared with about a 33% reduction in EMPA-REG. But dig a little deeper and the situation becomes increasingly complex, with many questions remaining unanswered.
My name is Carol Wysham. I'm an endocrinologist from Spokane, Washington, and I was the site principal investigator for the Canvas study.
Carol believes that the markedly different trial populations may contribute to the contrasting results. 99% of the EMPA-REG population had pre-existing cardiovascular disease, whereas this was true only of around 65% of the Canvas population. The remainder were considered high risk, but were free of clinical disease at study enrolment, representing a primary prevention population.
The differences with EMPA-REG is that the magnitude of the decrease in risk for death from cardiovascular disease did not come anywhere near the same percent reduction. Part of that could be driven by the primary prevention cohort. We don't have a sub-analysis of the difference in how the primary prevention cohort differed from the secondary prevention cohort, and that information is obviously going to be very important in order to try to compare between the EMPA-REG study and the Canvas-R study.
And Laurie agrees that the mixed patient population is likely to have affected the study outcomes.
The fact that the Canvas patients were in for 6 years is very unusual in all of our cardiovascular outcome trials. So there's lots of rich long-term learning, but the fact that it took 6 years to get a small number of events really speaks volumes to the effect that the primary group had.
A larger issue surrounding the Canvas results has been the increased risk for amputations, which even before the official trial publication had triggered the regulatory authorities to place warnings on the labels for all SGLT2 inhibitors. Carol's initial reaction was to avoid use of canagliflozin in patients with peripheral vascular disease, but examination of the full Canvas results prompted a rethink.
After reviewing sub-analysis data, it is apparent that patients with peripheral vascular disease and even amputations enjoyed even a greater reduction in their risk of CV events, MACE events, and therefore it seems inappropriate to withhold a therapy for a patient that is going to also have other benefits. And again, looking at the relative reduction in the number of MACE events compared to the number of amputations that occurred, it still is in favor, balance would be in favor of using the medication. And, given that the cardiologists are really convinced that this is a perfusion issue, so either related to volume depletion and relative hypotension or both, I think this complication can be mitigated by just very careful analysis of patients' volume status, blood pressure, adjusting medications as appropriate, and really emphasizing the importance of adequate hydration. And then finally, I think one of the major messages that I have taken home to my practice is the importance of doing a good foot exam at the time that we're considering starting any SGLT2 inhibitors. So whereas, we typically would do a foot exam at least once a year, I'm now literally taking shoes off and making sure that there aren't any changes to suggest significant ischemia. And if that's the case, then we may want to do something else, get them to the vascular surgeon, make sure that there isn't anything that is limb-threatening before we start the medication.
What's more, the increased amputation risk, which has so far appeared in just one clinical trial of one SGLT2 inhibitor, is not yet a closed case. Laurie again highlights the long duration of CANVAS.
When you follow complex people for 6 years, there is a natural progression. And so what of these endpoints that we found might just have happened regardless? And is this going to be a fluke of randomization and luck that they got unlucky, like bladder cancer and dapagliflozin? While I would appreciate the hesitancy to prescribe in a certain population, I think that we also really need to understand more about the things that no one anticipated, like amputations and fractures, because thinking through the class and other agents and the big databases that are out there in terms of post-marketing use, no signal. Yet if you're going to get a signal, you typically get it in post-marketing use. I think that that's the time course of these actual risks that we're concerned about will be very interesting, and volume depletion could be one explanation. Did people feel so well that they got up and moved more and they stubbed their toes more? Like, was there more injury? Like, amputation just doesn't happen for one or two reasons. There's multiple things that contribute to it.
Another issue with such large clinical trials, and the CANVAS studies involved more than 10,000 patients for nearly 700 centres in 30 countries, is the large variability in local conditions.
My concern as well is, where were these studies done? What countries and what percentage of the patients came from the various countries?
And where did these things occur is a great point, Carol. Yeah, I never thought of that.
Because if I use the example of, people in India. I mean, they wear, little flip-flops is about the only thing they wear for shoes most of the time. And then they take them off whenever they go inside. They don't wear shoes inside. And the likelihood of having injury in that setting, and also the difficulty to keep an injury clean. And so I'm using that as an example of what would be very different in Spokane, where everybody wears shoes because it's so damn cold all the time.
Or they have access to better foot care, or they have access to better footwear, or they have access to specialty care. And is there something that would have been preventable?
And still to be formally ruled out is the possibility that the increased amputation risk is simply the result of a statistical fluke. In the meantime, it's a subject to speculation, according to Carol.
There has been some back-of-the-envelope calculations for EMPA and amputations, and the percents of patients who had amputations, or the rate, actually, of patients who had amputations was the same in the EMPA-treated patients as it was in the CANVAS-treated patients. But the placebo was the difference. So the placebo rate was lower for CANVAS than it was for EMPA. So the actual rates were the same. So that I find that kind of an interesting mental exercise.
The markedly different study populations of the two trials don't allow for direct comparisons, but a quick calculation does suggest that the amputation rate in EMPA-REG was a little over 6 per 1,000 patient years in both the placebo and empagliflozin groups. This is very similar to the rate seen among canagliflozin-treated patients in CANVAS, but double that of the CANVAS placebo group. While these questions remain unanswered, Laurie worries that the reported side effects, which also include genital infections and potentially fractures, may discourage use of SGLT2 inhibitors in patients with diabetes and impede further research into the medication class as a whole.
And so having the class is huge outside. In cardiometabolic, it's huge. cardiometabolic renal. It's huge, and we have lots to learn, and I just hope that we can get the information that we need, that we can feel confident that these risks that have been identified can be identified, explained, and aren't something that's going to become a class killer. So I hope that the promise that we hold today continues throughout that, what we have going on, because all of that is what our patients need. A little bit of this, a little bit of that, a little bit of something else, and because they have all three systems involved. So that's what I think.
I agree with you in terms of the concern that nitpicking all of these DKA and the fractures and the amputations is going to be problematic for the class, and probably more so for mechanical flows.
And it makes a DPP-4 to prescribe for a primary care provider much more attractive, because they don't have to worry about any of that stuff.
So the publication of Canvas has raised as many questions as it has provided answers, although some of these questions may be addressed by further analyses of data from Canvas itself. In the meantime, our forthcoming companion podcast with John Wilding from the University of Liverpool takes a broader look at the SGLT2 inhibitor class as a whole and where it sits in modern diabetes care. And finally, a big thank you to Laurie and Carol for taking the time to share their thoughts about the Canvas trial.